join us live, they'll at least have a sense of the conversation and the content that we covered during this session. We'll also be breaking into virtual breakout rooms. So in some of the activities that we're going to be doing today, we will automatically sort of put you in a smaller room so you can have a smaller conversation with, 3, 4, 5 people as opposed to us talking in a big group. We will handle that on our end. We've done it a few times before and it seems to be pretty successful, but if there's sort of any technical difficulties and you run into anything, please feel free to chat us individually and we'll help you sort of navigate that process, hopefully. I think those are all of the things that I wanted to say in terms of logistical things. If you have any questions about any of that, please feel free to either chat me directly or chat everyone, and we're happy to answer any of those questions. But I think with that being said, I'm going to hand it over to Natalie to kick us off and get us started.
Thank you so much, Gina. Can everyone hear me? Can you do a thumbs up if you can hear me? Awesome. So hi, everyone. My name is Natalie Cashin, and I was unable to join you for the first training of this cohort, and was sorry to miss, but I heard that there was lots of great discussion and a really great start and kickoff to this cohort. So I'm happy to be with you here today. So today we're going to be shifting slightly from what you all were kind of focusing on and talking about in the first training around biases and examining kind of what we're bringing to this work. And we're going to be taking a kind of a larger look at this in terms of what does health equity work in public health look like? What does it look like now? What does it look like in the past? And kind of explore some of those ideas with you today. So as Gina said, the training, we're going to try to make it interactive, not always easy with a webinar, but we will be doing some breakout groups and things like that. So hopefully, try to bear with us if we have any snafus. I'm also here with Mo. Mo can just kind of wave at you. He's going to be co-facilitating with me here today, and you all have met him last time. So we'll start off with our learning objectives. So we have 3 today. The first is we're just going to define health equity. There's a lot of different definitions around this work and a lot of different versions of what folks might think about when they're thinking about health equity specifically. So we're going to share definitions that work for us and that we're kind of going to be using for this training and our context in this cohort. Then we're going to be examining sort of the evolution of health equity work in public health. What does that look like? And more specifically in relation to race and racism in our society and where are the parallels to that in public health work. And we're also going to be spending a little bit of time at the end talking about what we mean by upstream strategies to move our work towards addressing equity. And we only have an hour and a half to accomplish all of those things. So we're going to try to fit in as much as possible. And I want to assure you that whatever we don't get to today, or if you're feeling at the end that we really want to talk about this some more, we'll be able to revisit some of this stuff in our last training in a few weeks. So the first thing we're going to do is a little bit selfishly for me, but also for you all to be able to spend some more time getting to know each other, is we're going to do introductions again in a similar way that you all did in the first training. But because we're in a webinar, we're going to be doing it in smaller breakout rooms so that you all have some time to really introduce yourselves and understand and get to know one another in like a smaller group setting instead of open here on the webinar. So what we're going to do in a minute is break you all into those breakout rooms. And I would love for you to share your name, your pronouns, if you feel comfortable sharing those, and also your race and ethnicity, because I think we talked about that last time. And then we're going to also talk about the window again in a minute. So the window, if you'd like to share that. And the last thing I'd love is for everybody, if there's a thought or a feeling or any kind of questions or anything that is still resonating or thinking that you're still thinking on from the last training, if you want to share that, that'd be great as well. We're not going to have too much time, so try to keep them concise, but we still want to be able to have some reflection on last time. Before we do that, I'll go ahead and put this back on the screen. So this is the window of affect tolerance that was kind of presented to you all in the first training. Really, this is really about understanding and thinking and feeling what's in our bodies in terms of how we're doing. So rather than other check-ins that might be like, how are you feeling, or, you know, emotionally on a scale from 1 to 10, this is really about paying attention to our bodies and how our bodies are sending us signals about how we are experiencing just life in the moment. And it's really moment per moment. So, you know, depending on the topic and depending on how you're feeling coming into this training and you, or what happened to you this morning, you might be any kind of place on this window. So if you need more clarity around that or have more questions, maybe your small groups can kind of help figure that out with you all. And yeah, so we're going to go ahead and do the breakout rooms now. I see some questions coming in the chat room. Are we good to do the breakout? Okay, wonderful. So in a second, things are going to get real crazy on your screen, and you're going to be kind of put into a breakout room with a few other people. Once you all arrive there, go ahead and unmute yourselves. If you have the ability to share your video, I really encourage you to do so, especially when we're in these small groups. If you don't want to share it when we're back in the larger group, like right now, that's totally fine. But just while you're in the small groups, if you feel comfortable, I really encourage that. And go ahead and do these introductions with one another. Awesome. Go ahead, Tanai.
Hello.
Hello.
Hi, this is Emily Herzig.
Hi, Emily.
We'll go ahead and put you into a room right now, Emily. Give us 1
Thanks.
second.
Sorry about that.
It's all right.
It looks like Liz Parsons is also in this large room. Yeah. Hey, Liz, can you hear us?
Yeah, she was put into 2 rooms, one with her laptop connection and one with her phone, but she can't talk via her laptop, only her phone.
Okay,
Right.
cool. As long as she's in the right place.
Yeah. So she said, oh, she wrote to me, she's not sure how she can get back in.
Yeah, I would have to recreate the rooms, put what we see over here back in. So I'll just make note of their rooms if you want to just invite them to introduce themselves to the full group. Because there's nothing I can do at this point without shutting down all the rooms.
Yeah.
Wait, so she can't go back into a room?
No, I can't add people once the rooms are open.
Yeah. So it looks
Oh.
like Liz and Joshan are here in the main room. Maybe we can chat with them. Just us.
And
So-
Emily,
Yeah.
Emily, you with us here too?
Yeah,
And
yeah, I'm
Emily,
here
yeah.
too.
Yeah, sorry about that all.
Okay. Well, why don't we do a quick round of introductions of the folks who are with
That's
us?
perfect.
I'm Mo Barboza, and I serve here at Health Resources in Action. I am African-American Cape Verdean, and I rock he, him, his. This morning, I'm at like a -2. I was at a late function last night. There's a bunch of construction in front of my house till like 3, 4 o'clock in the morning, so I didn't get a whole lot of sleep, but I'm on my way up. Emily, you want to go next?
Hi, this is Emily Herzig, and my pronouns are she, her, hers. I'm white, and I'd say that my number is around between a 1 and a 2. I'd say I got a good night's sleep. Sorry that you didn't, Mo.
All right. And
Who else?
Liz?
Yeah.
Liz, are you still with us? Anybody else in the big room?
Oh, maybe the other people got somewhere else.
All right. So maybe it's just you and
You and us.
Emily, any reflections from the last training?
Yeah, I left there feeling kind of a lot of white guilt, actually. But I did my homework and I read the groundwater piece and I watched the video, and I'm inspired, I guess, to move forward today with talking about wake woke work, and yeah, that's where I'm at.
Awesome.
Awesome.
And thank you for following through on the work. That's we want to encourage that part, and hopefully you found the article enlightening as well.
Yes.
Cool. And I'm just went blank. Which video was this?
The wake.
It was a video. I can't remember the name of the.
Yes. Okay. Yeah. What did you
You
think
got
of,
it right.
of that video?
Yeah. I thought it was great, and it did help me think a little bit about where I am on that spectrum.
That's great.
And I think I'm probably, I'm hopeful that I'm in the woke situation, at least.
Okay.
Great. Well, I think we're going to go ahead and bring the folks back now. And so thank you so much, Emily. And we'll try to work it out so you get put into a breakout, make sure that breakout room works this time. And
Okay,
so,
thank you.
yeah, there's a couple people in your situation, so.
I get a 1 minute warning. Should all be.
Some of you will recall a show called Romper Room.
Mhm.
And this is what that feels like. I see Valerie and I see Carly. And I see Michael and yeah. Hopefully we're all back.
Yeah, so I think folks are still on their way back. So we'll give folks a couple more minutes to make sure they get back to the larger room here. And then a couple of debrief things we want to chat about for that breakout whirlwind we just had. And then we'll move on to Mo's piece. Give folks just a little bit more time to come back from the rooms.
Yeah.
All right, great. So a couple of things. Hope you loved that little room shuffle. So we noticed a couple of things that happened. If you are joined by video and phone because you can't use the audio on your computer, that's totally fine. If you can chat your phone number with your name to Tanayo, that way she can make sure your video and your phone both go to the same breakout room so that you're able to see and hear and discuss in the same room. So hopefully when we do the next breakout, we'll be able to match that up. If you just go ahead and send direct chat to Tanayo, letting her know what your phone number is so we can recognize you and pair you up. So I would love to hear just a couple of sharebacks for folks who would like to share anything or any thoughts they had lingering from the last training. I would ask that you just share your thoughts from the training if you have one. So if you would like to, you can simply unmute yourself and start chatting. So we'll give that space open to anyone who'd like to share. Don't all unmute at once. I know that there's some thoughts from the last training, and I wasn't there, so I would love to hear at least one share back that folks have.
Hi, this is Valerie. I always enjoy the breaking into affinity groups. I think a lot gets done in affinity groups. So certainly for the white affinity group, I guess I wish it had been a little smaller instead of such a huge. It felt like a big group. And then we did break out into smaller groups afterwards. So I thought that was helpful too.
Yeah. Great. Thank you so much for sharing. Yes. Any other last thoughts before we move on?
This is Ashley.
Ashley.
Mo called me out. I feel like since that training, and this is what I shared in my small group as well, since that training, some of the things we went over, like windows and language, I've been like more conscious about in my day-to-day work, both like with this job, but also like personal life, like at the gym and everything. I've just realized and thought about things I hadn't before, which I guess maybe ties into the video that was sent out with wake, woke, and all of those things. So it was cool. It made me be able to reflect more.
Wonderful. Thank you so much for sharing. One last technical. Oh, go ahead. Yes.
Okay.
Go ahead.
Yeah, so I was just thinking about how much more reflective I've been about like practicing equity and having conversations in the workspace. I think when I came into to the cohort, I was really centering things in my experience as a woman of color in like more so friendships and colleagues in academic institution, but then just realizing that the work needs to also be done in the workspace had really pushed me to be more reflective about how to have like difficult conversations with coworkers or in other spaces where there is advocacy needing to be done and being done. So I really also appreciated the small group, at least the POC racial affinity group was a small group and really intimate, and the conversations had there were really beautiful, and I've been thinking about it ever since.
That's great. Thank you so much for sharing. And I think, thank you all for sharing. It's really great to hear that feedback. And I think sometimes in this work, how I imagine some of you feel is leaving trainings like that. It's hard to be like, what do I do? What do I actually do? What is the actual strategy to implement at work? But it sounds like some of you are finding ways to do it and implement this work in your daily life by talking about it, by bringing these conversations to the mind in your organizations without necessarily having like a list of concrete strategies. So that's really great. So we'll go ahead and pass things along to Mo. If you have questions or technical
Can I interrupt
concerns.
for a second? Can you hear me? This is Julie Fetterman. I finally just got a microphone.
Yes, we can hear you.
Okay, bye.
Wonderful. So I'm going to go ahead and pass things over to Mo for the next part. And if you have any technical issues or questions, go ahead and direct message those to Tanayo so that we make sure and see them, because Mo and I will be facilitating most of the time.
Great. Thank you. And I wanted to start out by just kind of giving a little bit of context. We're going to be talking about the evolution of health equity work in public health, but unless you're like completely, entirely 24 hours in public health work, you know that this happens against a broader context of the evolution of things in our country. And so in the United States, part of what was happening post the civil rights kind of era was a real struggle about what it meant now to talk about these issues and to think about these issues when some of those absolute barriers were being broken by changes in laws and the force of certain projects to better include people of color specifically, but other groups into employment, education, all the different areas of life. And so the conversation in some way shifted from thinking about civil rights to thinking about diversity. And so that's the context in which this public health work addressing that evolved to address health equity developed. And so I just wanted to give a little bit of a breakdown of what was happening there that then is also reflected in what's happening in public health. Basically, if we go to the next slide. Oh, sorry, go back. Apologies. We basically went from seeking representation where organizations wanted to have a person from a particular background or a woman or eventually someone who's LGBTQ to say that they had somebody in their organization that reflected that aspect of diversity. That was kind of the first wave of what organizations were doing, what communities were doing. Government in some way, kind of social groups even would have that one person. They would say, well, you know, our diversity is this person. Looking back at it now, that seems really quaint. Like, oh, that was really nice of you. Over time, we started to, in this country, to think a little bit more about how do we ensure that organizations who are working with populations were more reflective of those populations. So did you have representations, not just like one person of color and a woman, but if your population were folks who were from the Middle East, did you have somebody who was from the Middle East who connected with that community, who had not just language skills, but also cultural skills? If you were working in the African-American community, did you have African-American folks in your organization? And importantly, that it was heading towards some kind of proportional representation within organizations. And this era of thinking about diversity as making efforts more reflective of who they're trying to address also allowed there to be a greater voice for those communities. So it was a big step in that direction. Where this effort in diversity is now is really leaning towards being more reflexive. And we'll talk a little bit about what that is in the next slide. And I promise that I'll go not too deep into this because we can get in the weeds really quickly. But basically, reflexivity is the process of reflecting on yourself, the researcher, so this is a research definition, to provide more effective and impartial analysis. It involves examining and consciously acknowledging the assumptions and preconceptions you bring to the research and therefore shape the outcome. This was really about like, we've got to own our stuff and really get a good grounding in our assumptions and any of the preconceptions we bring to the work that we're doing, and be aware of how that could shape what the outcome of that work is. Reflexive teaching, I put this in this definition in here purposely because the work that we do very often is working with populations. Reflexive teaching approach involves the use of experience-based learning techniques which engage the whole person and stimulate reflection on experience whilst opening up the learner to new experiences. And again, about meeting the whole person. For our work, it's a blend of both of these, that we want to make sure that we are bringing our whole selves and creating a space for the people we're working with to bring their whole selves, and that we're acknowledging some of the baggage that we bring. So if we go to the next slide. In simple terms, representation was, we're going to have one person of color or one woman or one whatever. Very often, this was also the first woman ever in that space, or the first person of color or whomever. Being reflective was, again, trying to approach proportional representation for each group that you're working with, each group that you're serving. So if you're in a county that's 12% African American, that you would have, you know, some approaching that number percentage in your organization working. Being reflexive is really being conscious of our baggage, our differences in experience and power, and knowledgeable and able to communicate, lead, and engage across difference. So it's not that we are only going to have people of color talking to people of color. It's not that we're only going to have white people talking to white people. There are moments when that makes sense, but it also makes sense that we are having cross-cultural, cross-racial conversations, and that people are able to lead, engage, and communicate across those differences, and effectively bringing the work to whoever they're working with, so that we're not pigeonholing people into working with specific populations, because that doesn't work. So this was the evolution in the public health world. In the broader world, in public health, we were going through, as some of you are familiar, we do a lot with semantics. And very often, we are, in the old way, putting a new label on old work. Some of you are going to chuckle because you've seen this before. Someone used to be the director of social justice health, and now they're the director of environmental strategies. And so this mirrored that development in diversity, where during the civil rights era and even going into the 80s, there was a big focus on social justice. Into the 90s, we really started talking about environmental strategies and how we needed to be working with what was happening in the environment in which populations or individuals were experiencing bad health outcomes. That led us to really understand that certain populations were experiencing those conditions differently. So we started to really look at disparities. And as we looked deeper into disparities, we noticed that there were this broader set of forces, social determinants of health, that were influential in creating and sustaining those disparities, and obviously the inequities that we are dealing with now. This leap into health equity is basically in the last 10 years or so, a little bit, probably 2008, 2009, that it started really to gain momentum. And part of that was recognizing that we needed to go deeper if we were going to affect not just putting a Band-Aid on those disparities, but eliminating the conditions that were creating them to begin with. And so this move into health equity has followed that trajectory, as the country also has moved to thinking about how do we eradicate the things that are creating the disparities that we see. And so this is that jog through the language, and it's important for us in public health because often that evolution has included changes in strategies and in what we do, and it should. We should not be putting this label on old work. So, health disparities, and we have these two definitions here because we want to just make sure that we are clear. Health disparities are differences in the incidence and prevalence of health conditions and health status between groups based on, and then we can go through, this is a short list, but race, ethnicity in America, that's primal. Those of you who read the groundwater article see the point in that. Socioeconomic status still is a stratification that we are often using. Sexual orientation, gender, disability status, geographic location, some combination of these, and others. That's how we think about and look at health disparities. Next slide. Folks familiar with social determinants of health, I had hoped that by the time that this workshop, this webinar was on, we would have the Healthy People 2030. ready to roll, but we're not quite there. So this is still the definition for social determinants of health from the Healthy People 2020. And it talks about these as the conditions in which people live, learn, work, play, worship, and age, and that these affect a wide range of health, functioning, quality of life, outcomes, and risks. One of the things that happened between 2010 and 2020 was that the framing of what was a health disparity and what was a health inequity got really jumbled. And so into the Healthy People 2020, the definitions got even closer. We assert that a health disparity is the difference, but when we start to talk about inequity, it's really about things being unjust and that they shouldn't be there. It's not just that there's a difference, but there's a historical push or there's a disadvantage. There are forces that are acting on those differences and that it's unjust that it's happening. And that leads us to our next definition. And this is a definition of health equity. We put up two of these. One that's just really simple. Health equity is achieving the highest level of health for all people. This is one that comes from the World Health Organization, and it's a way of thinking about how we are doing this work. And then this one is from Healthy People 2020. Health equity entails focused societal efforts to address avoidable inequalities by equalizing the conditions for health for all groups, especially for those who have experienced socioeconomic disadvantage or historical injustices. And just calling that out, that it's avoidable inequalities, so things that shouldn't be there that have been created, equalizing the conditions for health. And it's important that we name that as equalizing the conditions for health, not just equalizing the conditions. And it means that some groups will need other things that other groups need. And then a really important focus on those populations that have experienced disadvantage and historical injustices. And folks recall, we talk about racism to include the system of disadvantage, because that's one of the spaces in which these two come together. Very often we're talking about racial equity and health equity. Important for us that we recognize that to talk about and to do work in health equity, we must address racism and structural racism. All right.
Thank you so much, Mo. So now we're going to take a kind of a deeper dive into what is all of this that we just talked about, that Mo presented. What does it actually look like, and how is it actually manifested in events in our history in terms of public health? But before we do that, I'm realizing that when we did the intros, a crucial part of it is that you don't know me and I didn't introduce myself in that way. So maybe that would be helpful. So I'm going to quickly just do that, just to make sure that we're all on the same page, even the playing field. So like I said in the beginning, I'm Natalie Cashin. I use she, her, and hers pronouns. I am white, and ethnically, I'm not really sure. There's mixed opinions about where we come from ethnically in my family. And I think that my window is probably about a 3 now, because I'm feeling a little bit elevated since I remember I forgot to introduce myself and all of those things. But I'm excited to be here, and was excited to hear the reflections from last time. And I think, Mo, do you want to just be able to talk about your window real quick?
Sure. I think I mentioned to a couple folks, but Mo Barboza, he, him, his, Black, Cape Verdean, and I'm at like a -2, but climbing. Might be at a -1 right now. -1, yeah, I'm getting there. I was up late last night, and there was construction in front of my house, and just didn't get a whole lot of sleep. So while I'm deeply excited to be here and I gain energy from being with folks, it's starting from a lower point, but I'm getting there.
Thank you so much. And thank you for your patience with that. So now we're going to do what we're calling a timeline activity. So essentially, you're going to be broken out into 4 breakout rooms again. This time, you're going to have either myself, Kelly, Tanayo, or Gina. One of us will be in the room with you. And one of the 4 of us will have a Google document that we'll be sharing with all of you in the room. And that document will have a list of historical events. Some of you will have historical events that are related to public health. Some of you will have historical events that are specifically focused on race and structural racism in our society. And the reason that we're kind of doing that sort of section specifically is, like Mo said, in order to do health equity work, in order to really show up and understand the systems that we're working with, we have to examine the structures of racism in our society. So in your group, once you get there, your facilitator will help by being the one taking the notes and numbering them. It is your goal to look at these historical events and put them in chronological order. They will not have any dates associated with them. You will not know by looking at it what year it belongs in on a timeline. So it is up to you all in your group to assign or kind of choose which events come first in the chronological order. Your facilitator will, again, be the one controlling the document, so they'll be the one kind of numbering that for you, but you as the group are the ones who will discuss and chat and decide what you think about the events. You'll have about 10 minutes to do this in each group. Then once we come back, it actually might be helpful if you want to make little notes for yourself about what order you put the events in, because once we come back, we're going to put all these events actually up on a timeline for you to see. And so you'll get to see what the actual order of your events was, but we're not going to call out any groups or make groups say like if their events were in order, but it's just for you all to see where the order of events. And we'll spend a little time, I'll spend a little time talking through the timeline, and then we'll move on to something else. If there's questions about that, go ahead and put them in the chat box. But like we did the last time, we're going to go ahead and break us into the chat or break us into rooms. And either myself, Kelly, Tanaya, or Gina will show up at some point in that room with our document and start helping you put them in order. Awesome. Thank you all.
I'm going to kick you all into rooms.
Hello.
Hi.
Let me know if you can hear anyone else in this conference room talking in the background, and I can step out. So how's the volume? Can you hear Natalie talking too?
I don't think so.
Yeah, I could just hear you, Kelly.
Okay, it sounds like Natalie's mic is picking up mine. So, okay.
Okay.
I'm going to share the document. Okay. Okay, can you all see my screen?
Mm-hmm.
Cool. So what we're going to do, we are going to take these 10 events, read through them. You all are going to talk, and I'm just going to kind of copy and paste things in order as what you all think. So there are 10 events, and so we're covering the first half of the health equity timeline. Now, do you want me to move? Sorry, we're just reconfiguring here. So I'm actually also going to get up and move. So I want you all, I am moving. So right now we can see what looks to be the 1, 2, 3, 4, 5 first events. So read through those, and then I'll continue scrolling so you can see all of them at once. So let me know when you're ready for me to scroll.
Ready.
Okay. And after we read through these, I'll try to either make the font smaller or condense it so there we can see at least as much as possible without me having to scroll. So I'm just going to do that now. Okay, so we can pretty much see everything for the most part. So we have the Immigration Act all the way down to the first National Sanitary Convention hosted. So I'm just going to make this slightly smaller, if that's okay with everyone.
Okay, is this good for folks or is that really difficult to read?
Looks okay.
Cool. So you all talk and then I'll put numbers next to the events that you think come earliest to latest.
Cool. Any thoughts on what the first event is? I'm leaning towards the Cotton Mather.
Yeah, I think the Cotton Mather or the Massachusetts passes laws concerned with shipping conditions because of the death due to overcrowding and sickness on ships.
And I
Yeah.
think somewhere around there could be the cholera epidemic that spreads from Asia to Western Europe, also with the slave population.
Yep. So the one about the Massachusetts passing the laws would be before the Atlantic slave trade was outlawed, which was in like the late 1700s, I think. But I feel like Cotton Mather is like a really old figure in Massachusetts, so I'm inclined to say that one was first, but I'm not entirely sure.
Okay, so it sounds like either the Cotton Mather or the laws around shipping conditions is either first or second. Which one do you all want to go with for the first event?
I guess I'm kind of looking at it differently. I'm trying to like compare a couple of them within there. Like, I don't know that I could start at first and then create like a direct linear thing. I think I need to move them around based on the context that I'm able to put them into. So like, for example, like the United States Sanitary Commission happened during the American Civil War. The Freedmen's Bureau, I would assume, happened right after. So those seem like they're in pretty good order. And then I would take something like the Immigration Act, which seems tied to Ellis Island and New York Harbor, which is kind of like the Industrial Revolution time. So that'd be slightly after the Civil War as well. So I'd maybe stack that after Freedmen's Bureau.
Okay, so I can start to kind of put these somewhat in order. So we mentioned that might have been kind of up at the top. This was close to the top. And Cotton Mather, where did that go?
And then would the Immigration Act and the World Fair would it be in the sort of same era too? No.
Where are you in the?
You can definitely move Immigration Act below Freedmen's Bureau.
Okay.
Yeah.
I mean, they're definitely within the same time frame. Are you guys not thinking maybe no?
No, that seems right to me.
Okay. So do we want the Chicago World Fair, we think, to come last? Or where do you think the cholera epidemic goes? Do you think that belongs at the end or should that be moved up somewhere?
Which one? Oh, okay. Thank you. That should be up.
Okay. Which events do you want to put that after?
Maybe under the MA passes the law concerned with, maybe it would either maybe be right before that, because I could see that, or right after.
Okay, well, I'll move it right after for now, just so we can kind of like, it's closer to where you think it is, even if it's not the exact.
That sounds good.
Can we put something in between 2 and 3? Because
Yeah, I
2,
mean,
it says,
yeah.
like,
I think that one might be before just because it seems like the next one is a reactionary.
upholding Jim Crow laws, which are
Oh, that's where you put it.
like,
Never mind. JK.
Black folks are like
Also, Mike, is Alexis in our group or is she just in your conference room?
She's just right next to me. Sorry.
Okay. No, I was just wondering if I was missing an answer.
Is it distracting? Should I move?
No, it's okay. So we have the first National Sanitary Conventions. Do we want to start with that, or do you think either the smallpox or the law about shipping conditions would be before that?
I think smallpox probably was first, the smallpox outbreak, which prompted national sanitary conventions.
I could see that too, and then I could see MA changing law after like attending such a conference.
Can someone say more about the sanitary conventions? Like, do we know that it's that early? That seems really early to me, but I don't really know.
I don't know, other than like public health history, sanitation being one of the like first big things because of surgeries and stuff. But that's also like near Civil War time, so it could be a little bit later.
Got you.
Yeah, I mean, I think Jon Snow was big into sanitary conditions and clean drinking water, like very early public health. I don't know exactly when, but I can sort of see it being one of the first events.
Okay.
I could be wrong.
Changing these to numbers, so it might be easier for us to say move 8 to number so-and-so. Okay. So we have smallpox leading to sanitary conventions, leading to laws around shipping conditions, and then the cholera epidemic, and then the sanitary commission. Do we feel good about that order for the first 5, or do we want to relocate any of those?
I do wonder if, like, I was thinking that, like, the shipping conditions laws, were those a reaction to the cholera epidemic?
Good question. What does the group think?
I don't know. Isn't it weird on number 5 though? Like, why does it say that it was created on June 13th? Doesn't that seem like hyper specific? Is that for a reason?
No, I think Tanayo has a background in history, and I think that's just her. Tanayo made this activity, and I think she's just a history buff and
She's just flexing some knowledge for us.
She really is. It's great. All right, so there might be some things we need to shift for the first 5, but let's keep moving down and seeing as we get later into this first part of public health landmark, so to speak. What do you think? So we have Freedmen's Bureau to the Immigration Act to the World Fair.
The Immigration Act one is hard because there have been so many. So I'm like, is this the one that did this? I don't remember. But I mean, the inclusion of the Ellis Island makes me think of like the early 20th century, maybe earlier, I guess, but I think it's definitely after the Civil War. And I would think that the World Fair is like definitely early 20th century. But
The language used for the Chicago World Fair makes it seem like something really old, but I wouldn't be surprised if it was like the most recent thing in this timeline.
Yeah, I was just at this, I was in San Diego this weekend and went to like a site where they had like one of those types of exhibitions, and they talked about having these things, and it's like much late, it's like 1930 something, it's like much later than you would think they were doing this kind of stuff.
Yeah, I mean, my thought was kind of like right around like the World War I sort of area, maybe right after World War I, like as a sort of beginning of globalism and an expansion of colonialism.
Yeah.
Cool. So do we feel good about the order of these events, or do we want to move anything around?
I still think 3 and 4 should be switched, but I'm not sure about that or not.
Okay. What do other folks think?
I think 2 should be closer to 4. So maybe that would be like switching around like 3 or 4 also. So that's the only thing that I can think of.
Okay, so do you think the cholera epidemic would go before the sanitary conventions or between 2 and 3? So would 4 go between, or would 4 go after 1 or before 3?
Probably before 3. Now that Mike brought that to my attention. That makes sense.
So we have a 2-minute warning, just so you know, maybe more of a 1-minute warning. I think we're in pretty good progress too. And just for full transparency, I actually don't know the answer to these, so I'm excited to find out too. Okay, so we have smallpox outbreak, first National Sanitary Convention, then the cholera epidemic. Is that the right order so far that we are agreeing on? Or did I mishear anything?
That seems right. Yeah, I think that's what we said.
Okay, and then moving on to the Sanitary Commission, and then Freedmen's Bureau, Immigration Act, and then Chicago World Fair. I mean, this sounds good to me. I'm seeing a couple nods.
Close enough, I think.
Tiffany, what edit would you make, do you think, since you said close enough? I want to make sure I got everyone's input before.
I'm just not knowing like any dates or times. I just think maybe we're like as close to the order as we can get.
Yeah, I would agree. Okay, cool. So I'll keep this up, and then it looks like we have the 50-second warning. So I will see you all in the large group, and I'm excited to also see the answers, but it sounds like we're pretty close, if not 100% right, but we'll find out. Okay, see you later. Thank you for your hard work.
Thanks.
People are coming back.
Yes.
Yeah.
Flavor and
That was fun.
Good.
All right. Can everybody hear me? Okay, great. I'm seeing nods. That's a good sign. Welcome back, everyone. I hope that was a good time. I hope it was like the best thing that you've ever experienced. I had a good time in my group. So what we're going to go ahead and do is, like I said before, we're not going to make every group share and then be like, you know, judging everybody on there, whether or not they got it in for the right order. So what we're going to do is we have conveniently for you all put to the public health events and sort of the racism events on a timeline together, because what we really want to do is think about these events in our history as public health professionals and as people living in this country, individually, but also look at the ways that maybe they're influencing each other or the ways that there's just some parallels. So I'm going to go ahead and start doing that. So if you can sigh or chat to your friends and say, oh man, I knew that was the 70s, if you would like to, but we're going to go ahead and just start through on the timeline. So it might be a little bit difficult to read some of the words, but if it was your events, you'll kind of be able to tell. So along the top are the race part, and on the bottom are the public health events. So, we're starting all the way back in the 1600s on the race timeline with Atlantic slave trade, and the Constitution codifying slaves as 3/5 of a man, moving on to the slave codes, then Dred Scott, and then the Emancipation Proclamation. So really understanding and seeing how our country, how we were bringing African people to this country illegally and through slavery, and how then we started to understand and the country started to build systems to sort of other Black individuals in the Black community in our country, and how that starts to progress along this timeline. On the bottom, we have the public health events, which starts off right around, in 1629 with Massachusetts passing laws concerned with shipping conditions because of deaths that were happening due to overcrowding. And yet we still saw these conditions being ignored when it came to bringing over African people to eventually become part of the slave trade in the US. So already seeing that parallel into here's a public health thing that happened, but where is the race, or how is it kind of fitting into the way that we as a collective society at the time are understanding race? Then we move into the smallpox outbreak, which may have been familiar to some of you in terms of the dissemination of sort of like this idea about how to do a vaccine and where that came from, and how a lot of it's attributed to Cotton Mather, who really took the idea from a slave that he owned, but that never is really part of the discussion when we're talking about the smallpox outbreak and vaccine. So that moving into cholera epidemic, and then the first national sanitary conventions, and then the United States Sanitary Commission being created. So these are two different groups. So one group did the top part of this timeline, one group did the other part. And so this was really just the start of where we're starting to see some parallels between the way that our society and our country is setting up systems based on race, and how public health either mirrors that or responds to that. So we're already seeing some of that parallel. So then we'll move on to the second sort of slide of this. So this might have been a continuation of the first two groups, but we have the passing of the 13th Amendment on the top, the Chinese Exclusion Act, which is the first law to limit immigration based on race, Plessy versus Ferguson, upholding the separate but equal and legitimizing Jim Crow. And then in 1924, the Immigration Act, which restricts the number of immigrants based on national origin. So that's kind of what we're seeing as we're, again, progressing through our understanding in this country of what race is and how we're going to set up systems based on that. And then along the bottom, thinking about, especially in conjunction with the 13th Amendment and then this Freedmen's Bureau being established to help freed Blacks who are moving from the South, but it's severely underfunded, which means that these individuals are really not getting the support and the care that they actually need to thrive in a new system that they're coming into. And then we see parallels with the Immigration Act of 1891 requiring immigrants to be given health examinations. So we're seeing new immigration law happening based on race, but then we're seeing a lot of, sort of response in terms of public health, in terms of the health of the people that are being allowed to immigrate into our country. Then they have this kind of event that shocks me and upsets me weirdly, because it's not one that is hardly ever talked about, but this random event about the World Fairs and how they have, they set up ethnic villages to display what life is like for all of these different ethnic groups, and really how colonized people were brought to populate these villages, and just like this understanding of history that was being presented to the public, and how it's kind of being reframed or retold depending on who is the population that's telling the story. So I know I'm moving quickly through this timeline, but we'll be able to send this out to you so you can kind of go deeper into this and have some more discussion. And I'd love for us to discuss more in the Google group too, but we're going to kind of move through this a little bit quickly. So then we're in the 40s, 60s, 70s, 80s with around the top. You can see we're starting to see a lot of different race stories being told, especially when it comes to different races in this country. So the executive order that says that the 14th Amendment was not being violated, and so it really upheld this right to discriminate against Japanese Americans and putting them in internment camps. And then the armed forces being desegregated, voting rights acts being passed, and then school desegregation. So we're changing the narrative a little bit around race in this country and understanding individuals of different races and how they play a vital role in our society, but not quite getting the full picture yet. And so along the public health line, we see kind of mirrored examples of this. So we're seeing propaganda videos about hygiene that are really highlighting how that are linked to race, and how hygiene is somehow related to race, and that's happening around the same time as the Japanese American internment camps. The Clean Water Act is passed. Controlled Substance Act is passed, but it does not include tobacco. And this is amongst a history of the tobacco industry, specifically targeting the Black community with menthol cigarettes and with different ads. So it's interesting to see that tobacco is not really included in that Substance Use Act. And then this sort of real in-depth look at a specific case of thousands of Mexican American women who are sterilized without their consent, and how this is really a pointed example of how eugenics is really being deployed in the US. And it was after it was legalized in 1907. And this is still happening to this day in some places, that women are forcibly sterilized in prison institutions. And so this is just one example of kind of that bigger picture. And then we move into the 80s. And this is as we move further along the timeline, a pattern starts to emerge in terms of public health responses to different epidemics, and how that response is different depending on what population is being affected most. So specifically here in the HIV/AIDS scare, we're thinking about how when this first happened, it was really labeled as a disease that only affected gay men, and especially gay men of color, and it really was labeled as this sort of gay disease. And then once we started to see HIV and AIDS happen in other populations, especially in white mainstream America, the focus shifted from this is a problem for that community to this is a problem for all of us, and now we're going to put resources into things like sex education and harm reduction. So that's just an example of how that response changes depending upon who's being affected and what that says about who we're valuing in our society. And this is sort of the last piece here. Along the top, a lot more recent events. So some of this might be a little bit more familiar to you all. So the Rodney King riots in '92, Trayvon Martin being shot and killed in Florida in 2012. The Trump administration's zero tolerance policy in terms of families illegally immigrating, and how that's causing a huge problem at the Mexican-American border in terms of separating families. And then kind of on an upswing, Massachusetts recently, this is kind of a race and public health event, so it's kind of hard to know where to put it, but Massachusetts being the first state in the country to ban the sale of flavored tobacco products, including menthol. So those tobacco products that I said were targeted to Black communities specifically, now illegal to sell in Massachusetts. So it's a huge public health win, but also deeply rooted in race. And along the bottom, again, that example we see several times along the bottom of this public health timeline of how the conversation changes depending on who the population is that's affected. So, in '94, seeing President Clinton continue this war on drugs that was starting, and the criminalization and imprisonment of people of color related to drug use. But then if you go over to 2016, thinking about the opioid epidemic and how that has hit a high in the country, and how the response to that is much more of a positive public health response, where we're funding initiatives to help raise awareness about overdose prevention. There's a standing order for Narcan. And so just thinking about how the story is changing depending on the population. And so I won't go into all these events again, but just kind of looking at this timeline together, that's what it is there. We can read into the events or kind of try to see what's happening underneath the surface. But one of the reasons that we do this is because if we just look at the event itself, it's sometimes not telling the whole story. It's helpful to look at a collective history, and it's helpful to look at histories kind of in different spheres. So when we're thinking about race and history of public health, and how those things have kind of moved and changed and interacted together over the course of our history in this country. I just talked a lot, way too much probably. So before we kind of shift a little bit and kind of start to unpack and think about, so what do we do with this? If there's any, comments, questions, concerns that you all would like to raise really quickly before we jump into that, I'm going to pause just for a minute to let folks do that. If you want to unmute yourself with a comment or a question or a concern, or that they have a typo, let us know.
Okay.
Any initial reactions to this? It's a lot of stuff to be taking in and a lot of pretty heavy stuff. So even if you just want to share, how this made you feel and where you are in your window now after hearing all this stuff, that is also a great, and we welcome that too.
Hi, this is Liz. I'm
Hi,
on the
go right
phone
ahead, Liz.
and on the video.
Yeah.
I'd always heard the war on drugs and things like that, and just sort of taking in your presentation and having, working in substance use prevention now. I just think, our approach is not a war on drugs now, and I know it's been a lot of comment and awareness about the opioid epidemic and how the response is different now that it's affecting white people and mostly white men, where there's been an epidemic and a crisis in communities of color for years. In the 90s, it was called the war on drugs, and now it's, you see right there the 2016, like, how can we help with harm reduction and Narcan and things like that. So I guess I always knew this, but seeing it laid out like this and just seeing that term again, war on drugs, made it more, I don't know, just shocking and clear.
Mm-hmm. Yes, thank you so much for sharing. Any other thoughts? Yeah, you can.
I just wanted to mention that, that war on drugs is from the 70s with roots in the 60s. It's our longest fought war, quote unquote. And that it's also about a narrative. So the narrative about who was using and who was selling drugs in the crack era was about people of color. And in that space, the reaction to that narrative was these laws that we saw in the Clinton era and this really forceful approach, demonizing of people, and arrest people for using, when the actual users were not overwhelmingly people of color. It was mostly white people using crack cocaine and powder cocaine, but the narrative said something different. It's really important for us to also look at who what the actual numbers were, not just what the image of who was using. And one of the things that's really changed about this opioid epidemic is that the narrative right from the beginning has been a much broader set of folks, and specifically a white audience, a white group that was suffering, and a demand to do something to support that group. And so we see also that the narrative also dictates the reaction. So we have a different reaction to this.
Great. Yeah. I know that there's probably a lot. Is there one more comment, Valerie? I saw you had just unmuted yourself. We'll take one more comment.
Yeah, just to say, I love history. I listen to a lot of, and I've been listening to a lot of podcasts that talk a lot about the history that we don't know anymore, that's almost invisible. And I think this timeline is a very powerful way to share this information. So thanks a lot.
Yeah, you're welcome. And as I said, we want to continue this discussion about the timeline, and I'd love to do that in the Google group, kind of between these sessions, and in our next networking session, we could talk about it more too, because there's a lot to unpack here. But we're going to go ahead and move on just for the sake of time. And Mo's gonna kind of lead us in this next piece.
So this is literally from that, the list of things that you can't make this up. John Ehrlichman was an assistant to President Nixon, and he was also the White House counsel to the president. And these are the words that were recorded him saying in some testimony that he was giving. The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. You understand what I'm saying. We knew we couldn't make it illegal to be either against the war or black, but by getting the public to associate hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know that we were lying about the drugs? Of course we did. This is the counsel to President Nixon. So this is to say, like, this stuff is not accidental. It's on purpose, and people knew what they were doing when they were doing it. Important for us as we take on some of the challenges around health equity, that we have a clear eye on what's being done purposefully, and that we are willing to push back against those things in real time.
Mm-hmm. Yeah. So I'm just going to pause here for a moment to name the pre-work that you all had for this, which is reading the groundwater approach article. And because now we're going to kind of move from looking at and understanding this history and analyzing it to thinking about what does that mean for us in terms of the way we move forward with our approach to public health. Because if we can see patterns and see how see mistakes that we even made in terms of the way that we approached public health, especially from a racial justice lens, but how can we start to move that work? So one of the ideas or strategies to begin to think about this is the groundwater approach. And I'm not going to spend too much time here because you all read the article, but really understanding that instead of addressing the individual sick fish, or even the pond that fish is swimming in, or even thinking about all of the different ponds and, let's address all these ponds. Let's think about how do we really address what's really happening, what's really affecting all of these ponds and all these fish, and that is the groundwater that's running underneath. So thinking about, in this country, what is that groundwater? And oftentimes what we say and what we believe in this work is that groundwater in the United States is systematic racism. And that systematic racism and in the historical injustices that have happened to different populations and people of color in this country, that is the groundwater that is leading to poisoned ponds and sick fish. And so in order to address our work in public health, in order to do it so that it is long-standing and effective, we have to address the underlying systems of racism in our country. So that's kind of how we want to think about it. And Mo is going to talk about, so how do we do that? And we're going to kind of move through some of his sort of strategies that we're going to put out there for you all.
And I'm the first one to have not done the reading for a class. So if you didn't get a chance to read the article, it's a really good way of thinking about how do we hold this systemic racism that we see, where people are facing these issues in all the different places that they go, and where does it bubble up in our communities? And it's also, what I've really found useful is that it never really helps to go around blaming individuals, and that there are much bigger systems that are at play that empower or give power to people who are acting badly. And we have a much better chance of making real change if we address things at that systemic level. So, next slide. Some of you are familiar with this. This is adapted from our friends in San Francisco. And it's just to point out that if we really want to make big changes, we have to be working a little bit further upstream. And if you look at this, on the far right are things around mortality and disease and injury. This is where public health has been traditionally, and a lot of the work that we have done in the prevention world has been really focused downstream in that disease and mortality. And in fact, the ways that we usually are counting what we're doing and counting our successes are further down. In the last 20 to 30 years, we've really started to think about risky behaviors and addressing the living conditions, those two middle columns there that focus on the environment and focusing on changing behaviors by making the healthy thing the easy thing to do, all comes from this space of really changing the risk behaviors and in some ways affecting the living conditions that folks are in. And again, a lot of this is kind of after things have already happened. Health equity is pushing us to really think about what's the institutional power in place and what are the social inequities that we need to address such that the conditions for living are better and that people's behaviors are affected by those better conditions. And then we can really start to address disease, injury, and mortality in a much grander way. And so to be able to make that level of systemic change, we've got to be further upstream. And that's one of the reasons why this work is really about uncovering some of those inequities and really addressing them at the system level. Folks are familiar with the downstream, midstream, and upstream approaches, but I just want to make sure that we're all on the same page. Downstream approaches are interventions that seek to address immediate health and social needs of populations. Think about this as after you are sick or after you're diagnosed or after the condition has already caused an outcome. This is where downstream approaches happen. Midstream approaches are interventions that seek to reduce the exposure to health risks by either improving physical working living conditions or through promotion of healthy environments. We're trying to change the environments in which the bad outcomes are happening such that they lead to better outcomes. Good approaches midstream, but we're not actually addressing the underlying conditions that cause or are perpetuating those bad outcomes. Upstream approaches are interventions that seek to reform the fundamental social and economic structures that distribute wealth, power, opportunities, and decision-making. As you think about it, when we talk about racism, it is about the distribution of advantage, so it fits in here as well. Upstream approaches seek to address these things and try to reduce the ways in which they create conditions that cause the disparities that we see. Important for us to think a little bit about how our work is actually focusing on these upstream approaches. And so I want you to think a little bit about how do you move upstream from the work that you're doing? If you're doing prevention, how do you address those underlying conditions? If you're doing work that's topic focused, how do you address some of the things that affect how that topic, whether it's asthma or obesity or hypertension or healthy eating, how do you address the upstream factors? And you can definitely put things in that chat box. We'd love to hear a couple ideas about what folks might be doing there or how they make that leap. All at once now, okay, great. I'm hearing a lot of folks and I can't get you all at once, but maybe I could have like one or two people unmute and talk. And I see pictures and I know names, so I'm just gonna say, I'll give you a chance to jump in first. Tiffany, is that you? Wonderful.
Yes, this is me. So I think an approach that I like to take and that I've learned from my org is simply looking at the policies, right? So if you're noticing that a certain population in a certain city maybe has increased amount of not having housing, then just go look to see what in that city that you have access to is possibly impacting this, and then kind of building out your network. Who do you need to talk to? Who do you need to connect with? To kind of realize what is your landscape and what efforts, where do you need to direct your efforts with people that have the power to actually make policy changes.
Yeah. We'll take one other comment, and again, I'll let you decide for yourself that you want to step forward and comment, and then I'll call on Esmeralda. So go ahead. Is there a lovely soul that would like to jump in? Anything that you're doing or that helps you to think about going upstream? Well, I want to make one comment. One of the things that happens for our public health folks is that we get narrow in a topic, and when we start thinking about upstream, things seem bigger than what we are able to do something about, because we want to work at the same capacity and with the same directness that we're doing our individual narrow topic. Now we want to apply that to a topic that's a lot bigger. And that's really hard to do. What I say to folks is, if you're finding that housing is affecting obesity, it doesn't mean that you have to give up working on obesity to then address housing, but it does mean that you need to bring that effect to the folks who are working on housing and support that work so that it can have the effect that you're looking for on obesity. If you're working on healthy eating and you find that transportation is a thing that's really affecting that, you want to make the linkages with the folks who are working on transportation and make the case for health in that space, but not give up working on healthy eating while you're doing it. Important for us that we see that public health work is connective work that brings the idea of bringing everyone to their greatest health in the hands of more than just the public health professionals or the folks who are narrowly focused on public health. There's no reason why the Department of Public Works and the Department of Safety or police folks, as well as inspectional services and the CBOs and foundations in our communities wouldn't be addressing this topic that you are focused on. They need to know how it affects health and how what they do can affect the thing that you are working on. To me, that's always the best way to think about building the kind of coalition we need to really make changes when we go upstream. I'm going to pass it back over to Natalie to wrap us up.
Yeah, so I just want to sort of touch on one thing that I mentioned in the beginning of the webinar before we wrap up for today, which is I know that in general, when we're doing this kind of work, and by this kind of work, I mean talking about race and public health and what we should do about it and how we integrate racial justice strategies into our work, there's a lot, and I have felt it so often, there's like kind of a huge feeling of, this is exciting, I'm energized by it, I get it, but how do I do it? How do I put it into action? What is the actual thing I do at my desk, at my organization when I get back to my work to like make this happen? And I think the thing that's hard about this work is that there's a real tension there, because the sort of core of this work is that we have to be, like we said in the beginning, those researchers, those explorers that are kind of understanding the biases we bring, going deeper to understand some of this history. There's so much to unpack, as we saw on the timeline, when it comes to how these systems of racism have happened in our country. There's so much to unpack, both on the systems level and personal level, that it takes a long time to get to a place where we actually can take real action, because we have to be doing this work to examine ourselves too. And so I think that's why we wanted to give that video that we gave you all for the pre-work, that I think that's Wake Woke Work video, talking about people lie on a spectrum when it comes to this work. Either you're just learning about this, you're just really becoming awake to these ideas, or you're woke and you can talk about it and you want to be in this space where you're really diving in and unpacking some of this. And then moving on to the work where I can actually talk about it, live it, breathe it, incorporate it, view my work through this lens so intentionally that I can really start to apply it to my work. And it is really hard to get to that workplace, which is why there are not a lot of great examples of upstream sort of things that are addressing systemic racism in our country. There's just not a lot of really great examples because it takes so long and it is so hard to get there. So I want all that to say is that I want us to be able to congratulate ourselves for being here and doing this and being in this cohort and talking about this, because this is part of the work. Doing this and coming to this cohort and showing up and being in these conversations is part of the work. And giving ourselves a little grace to not want to jump to have an answer to everything right now. It's going to have to happen over time. It's such a cyclical process. So I just want to say that and say thank you all so much for being with us and doing this cool technology thing with the breakout rooms. I think it's really great to change up how we're doing these types of trainings to be more accessible. So yeah, I want to say thank you. Mo, any last comments?
So much of the work of making this happen is about us doing enough of the self work to be able and ready to assist other folks as they're doing their work, and so that we can actually do the work that affects communities. A really jazzed, energized individual going against a system that doesn't know anything about what you're talking about doesn't get very far. But when we do that work and we integrate it and build allies within those systems and bring some of this work to them and ask them to be as reflective as we're being reflective, then I think we have some entrees into really making changes in those systems. So I want to encourage you to keep doing that self-work, to make it contagious. I know that's a hard word to say in public health. Make it contagious that you would work on the things that you're working on. Share it with the people who you work with, who you want to get better at this work, and then build that into the allies that you're building in the systems you want to change.
So we'll wrap up with some sort of next steps and things. Firstly, I want to say that we really value your feedback. Your feedback from the first training is really helpful in sort of actively helping us shape what this training and the next training look like. So Gina's going to put a link. I know she put one link, but it's not the right one. So wait till she puts the second one in there. A link to the eval form in the chat box. It will not automatically just like pop up for you after this meeting because it's a Zoom meeting and not a webinar thing. So you have to click on it in the chat box to open it. Please fill that out for us, and we take your feedback really seriously. Our next training is in a couple of weeks. What is the date, Kelly? Can you remind me? March 24th. March 24th. And that will be our next in-person one. It'll be at the same time, 9 to 1, at the same place at UTech and Lowell. But before that, we have a networking session, which is going to be a pretty informal, like guided, I don't know, chat about, but we can all take some more time to talk. It's going to be virtual like this is. I'll be there to chat through some of this stuff. We can talk more about whatever you all want to talk about. And that'll be happening, I think, in a couple weeks. So we'll be sending out all the reminders for that and ways to log on to that in soon. So be on the lookout for that. And yeah, thank you all so much. We look forward to seeing you again. The networking session, Mo just told me, is on March 11th, so that's great. And I will look forward to seeing you all then. Thank you. Bye.
Thank you all. Bye-bye. High five.